Good evening, everyone. Welcome to the August edition of the Scleral Education Society's webinar series. I am your moderator, Dr. Ashley Tucker, and it is my pleasure to introduce Dr. Trevor Fosso. He will be speaking to us about under the scleral, corneal complications of scleral. Dr. Trevor Fosso serves as the Director of Contact Lens Services at Pinecone Vision Center in Sartell, Minnesota. He joined the practice in 2017 after completing a residency in anterior segment disease and medical contact lens management at Davis Duer Dean in Madison, Wisconsin. He lectures and writes on topics of anterior segment disease management, surgical co-management, and contact lenses with a special interest in keratoconus and scleral lenses. Welcome, Dr. Fosso.
Thank you.
This is just Dr. Fosso's disclosure slide. And just a couple housekeeping things. So tonight, if you would like to have a question presented to Dr. Fosso, please feel free to put it in the Q&A feature or in the chat feature. I'll be monitoring that throughout the webinar. And after the webinar is complete, we'll spend the last 5 to 10 minutes answering those questions. Just a reminder, to receive CE credit, you must remain online for a minimum of 15 minutes for COPE credit. Again, and attendees are welcome but not obligated to stay for the Q&A at the end. To make life so much easier, I totally recommend that you download the OE Tracker app if you haven't already. It makes this so much easier. If you have this app ready with all of your information in it, we will be providing a QR code at the end of the webinar that you just scan, and your credit just kind of instantly shows up in the app. But if that's not something you want to do, CE certificates will be emailed within 2 weeks. All right, so I'm going to stop sharing my screen and I'm passing it over to Dr. Fosso.
Perfect. Yeah. All right. Well, thank you, Ashley and the Scleral Lens Society for having me, and thank you everyone for joining us tonight. Like she said, my name is Trevor Fosso, and I practice in central Minnesota, about an hour northwest of the Twin Cities. I work in a group private practice. We have 8 ODs, but we're pretty medically focused. We're a big kind of referral practice for surrounding ODs. And really my area of expertise is kind of anterior segment disease, surgery management, and then specialty lenses. And I really enjoy working with scleral lenses primarily. So tonight I get to talk about scleral lenses and kind of some of the specifically corneal complications with scleral lenses. There we go. All right, so here are my financial disclosures. So tonight I just want to go over a little bit first, kind of what is our plan. I'm going to go over a little bit about scleral lens usage. So I'd like to just kind of look at the market for scleral lenses whenever I talk about them. I'm going to go over some helpful tests that I always like to get on my patients, both as a baseline and then using as tracking as we go throughout the fitting process. And then we're going to get into a variety of case examples of some of these different complications that we run into. So like I said, to start off with, just going to look at kind of the scleral lens market. And so this is from Contact Lens Spectrum, their annual market share review that they publish every January, where it just compares the market share from the 2 years prior. And so this was published in January 2023 this year. Looking at the scleral lens markets or the overall contact lens market from 2022 and 2021, and we can just see, scleral lenses are up to about 5% of the total market, which is up from about 2% the year before. So we've definitely got kind of some good growth there. When we're looking at just GP lenses in general, scleral lenses last year made up about 21% of the GP market overall, and that's up from, again, 14% from the year before. So definitely, again, a nice growing area of GP lenses. And then also, just looking at a study that was published in February of this year, looking at the prescribing habits of scleral lenses for the management of corneal irregularity and ocular surface disease, published by some of our colleagues. The main thing that I highlighted here is, scleral lenses have become or are the most frequent considered as the first choice management for correcting corneal irregularities. So there's been this shift where we've gone from corneal GPs kind of taking over most of the market to now we're getting to a point where scleral lenses are growing and becoming more and more of the market. And, we see this in a lot of publications when we look from contact lens experts, researchers, things like that. But I also found in looking this up, this was published in Fortune Business Insights. So looking at the scleral lens market from just a financial and business side of things, not related to eye care or eye care professionals, but this was published in January of this year. And they looked at the worldwide scleral lens market, and in 2020, it was about $208 million US. In 2021, it was about $240 million US dollars. But it is projected to grow to about 646 million by 2028. So nearly triple in size. Like they're, even business experts are looking at the scleral lenses, the scleral lens market, and saying, hey, this is going to grow, and we're expecting it to almost triple in size over the next 6 or 7 years here. And really, they believe the primary reason that this is growing is because of the prevalence of ocular disorders, dry eye, improving reimbursement, and then just also increasing the accessibility of scleral lenses to different practitioners around the world, improving the technology that we have with the lenses and what we can do with the lenses and in terms of fitting them and everything like that. And again, the main reason I wanted to look at that is just to say, scleral lens usage is growing significantly, and it's really, growing, and it's, there's not really any indications that it's slowing down or going to stop. And as we see more scleral lens patients, we're going to be seeing more and more complications, not necessarily a higher incidence rate of them, but the more that we see of them, even as we get better at fitting them, we're just going to encounter these more often. And so it's good to be aware of what are some of these complications that we might run into. Like I said, the next thing I wanted to talk about was just some of the baseline testing that I like to get on all of my scleral lens patients when I can. I'm fortunate enough to have a lot of different technology in my office, but even if you don't necessarily have it, finding someone who can get some of this baseline information for you can be very helpful. But obviously, when dealing with contact lenses and different corneal conditions, diseases, having a good corneal tomography, topography, being able to look at that anterior corneal shape, posterior corneal shape, elevation, just to kind of get an idea of what's going on. And then being able to track that and see how that cornea is changing, whether it be working with a condition like keratoconus and see if that eye is changing. Even though you fit them with a lens, their eye can still change if they haven't had cross-linking, or even if they have had cross-linking, they could potentially develop some change. So being able to track that with these patients is important. Corneal pachymetry, being able to evaluate that corneal thickness, especially on our endothelial disease patients like Fuchs, pseudophakic bullous keratopathy, different things like that. And our corneal transplant patients, many of them end up in a contact lens. We're kind of moving towards more scleral lenses with these patients. So being able to monitor that to see if we're having issues with edema. And then being able to track those changes in corneal thickness as well as we're going around. You can see on these pachymetry maps off to the side, these are actually all the same patient starting in the upper, I believe, kind of left-hand side or upper kind of middle one. He started at about 924 microns, eventually got down to about 801 and 785, and then is down to about 695. So, he lost about 250 microns of thickness there over time, but being able to track that is very helpful. With corneal pachymetry, I'm also a big fan of global pachymetry. So again, I'm fortunate enough to have an instrument where I'm able to measure that global pachymetry as compared to just a single measurement. Unfortunately, a single measurement, while it can be helpful, doesn't really give you an idea of the whole picture of what's going on with that cornea. And we may have isolated areas of corneal edema like we do in this patient, where he has significantly more edema inferior nasal right along this gentleman has a transplant that's a little ectatic in that area, kind of bulges out. But you can see how his cornea edema kind of went down, but it didn't necessarily change everywhere for him. So being able to look at the overall corneal thickness is helpful. Anterior segment OCT imaging, again, if we have it available is great. We can get really good detailed corneal imagery. Certain anterior segment OCTs, we can look at corneal pachymetry again. I'm fortunate enough to have an instrument that I can do that. And again, gives you a nice global view of that pachymetry. But what I've really found helpful with that is epithelial thickness mapping, being able to look at just that straight epithelial map. We know with certain conditions, they tend to present with certain presentations on that. Like in this case, we see that donut pattern in patients who have keratoconus, where it's a little thinner over the apex, it gets thicker around there. So being able to track and monitor that on some patients can be very helpful as well. And then also with anterior segment OCT, just being able to more thoroughly assess the fit of our lenses and be able to use that for consultation, looking at the central clearance, edge alignment, limbal clearance, everything like that can just help improve the fit of our lenses as well. Specular microscopy or endothelial cell counts are great to be able to evaluate that endothelial cell shape, size, and density, again, for our patients with conditions like Fuchs or pseudophakic bullous keratopathy, but especially our corneal transplant patients, because we know those transplants, they lose quite a few cells within the first year of having that transplant. And we know that if we start getting below about 800 cells per millimeter square, we run a higher risk of developing edema. So we want to play it a little more careful with those patients in some of those situations. One of the biggest tips that I have, though, especially with any of this instrumentation, and this is something that I've changed, is rather than just getting a single scan, it can be so helpful to just get multiple scans. Especially I've noticed this even more so with our specular microscopy. Sometimes, especially some of these corneas that are a little more diseased, they might have some type of scar or haze or some irregularity. You get kind of some difficult glare, and so you can get quite a bit of variability in the endothelial cell count. So I've got two measurements on the same patient here, and you can see the right eye is roughly the same, but the left eye, in one measurement that was in December, or actually we'll say the first one was in July, and that was 860 cells per millimeter squared. But then in the following December, so 5 months later, is measuring 1,800 cells per millimeter squared. So he didn't necessarily grow 1,000 more endothelial cells in that time, but there's just some variability in there. So I've kind of gone to the point where now I get, multiple measurements, see what those all look like, and then kind of figure out, all right, what might be the most accurate one there. And then finally, especially with anything going on with the cornea, external photos, I don't think it can be any truer to say, a picture here is worth 1,000 words, whether it be working with consultation to say like, all right, here's what I'm seeing. They can help you out there, but just being able to track changes on the eye, being able to go back and assess the lenses a little bit more, having those pictures whenever you can is a wonderful thing. And so I love always, we have a few of our lanes that are decked out with slit lamp cameras. And so I always like to try and get in those when I have my scleral lens patients coming in, whether it be, like I said, just using it for consultation or just for my own reference down the road. All right, and so now we're going to get into some of our different corneal complication cases here. So we're going to go through, these are all a variety of patients that I've seen for the most part. The first one that we're going to talk about is Arlene. So Arlene is a 76-year-old female who is coming in for just a 6-month cornea check, scleral lens monitoring, and some glaucoma testing. So she has a history of scleral lens wear just in her left eye for, she's been wearing a lens for about 18 to 24 months, so about 1.5 years, 2 years. She has a history of neurotrophic keratitis with a really bad neurotrophic ulcer. After she had cataract surgery, she developed a retinal tear, had surgery, and then became very neurotrophic after that. And so a cornea specialist referred her to me, fit her in a scleral lens, and she had been doing great for a while. This is a picture of her eye. You can see the scleral lens on there. Eyes overall looking pretty good, everything like that. And she's coming in. She says, overall, everything's been doing well, but she has noticed the vision's a bit blurrier for about the last month. So she comes in, she wears glasses for her right eye. She's about 20/20 -2, which is pretty stable. Left eye, she's 2200, pinholes to about 2080. And just a few months prior, she was 2060 in that lens. So definitely a big drop in her vision. Entrance testing's normal. Take the lens off, look at pressure. She's 12 in the right eye, 25 in the left eye. So definitely a little elevated there. When I take a look with the slit lamp, right eye looks normal, but with the left eye, she's just got diffuse edema. And then she's got, you can see this very large kind of blistered bullae down here at the bottom. So Arlene was diagnosed with corneal edema secondary to her contact lens. So we had her halt her scleral lens wear. We started Lotemax 3 times a day, ofloxacin 3 times a day, and I put her on brimonidine as well 3 times a day. So with corneal edema, it is the accumulation of fluid within the cornea, typically without inflammation. Patients, they'll come in complaining of blurred vision, potentially halos, maybe some photophobia, and potentially pain and discomfort. If there's enough edema, typically around 10% or more, patients are going to notice like, hey, this is uncomfortable and my eye hurts more. Clinically, you're going to be able to take a look and you'll see bullae, so those little kind of water blisters, potentially some microcystic edema. They might have an epithelial detachment like Arlene had. They'll start to develop some haziness, potentially some striae or folds within the stroma or within Descemet's membrane. And eventually they can lose transparency of the cornea, where it starts to get harder and harder to see the iris, again, as you get more edema. The edema is there long enough, they can start to develop neovascularization. We'll see some negative staining with those microcystic edema. We'll even start to see the cornea change shape, and obviously we'll be able to see its thickness change in size as well. So again, here, all the testing that we can do, having that specular microscopy as our background, looking at topography, pachymetry, anterior segment OCT, all of that can be very helpful. But I will admit, for Arlene, we've tried to get a specular microscope or a spec mic on her, but she's got a really deep ulcer right in the middle that's pretty hazy, and it's hard to appreciate on the photos for her, but it just blocks the spec mic, so we haven't been able to get a spec mic on her left eye, despite trying about, every time she comes in, we try, but we haven't gotten it yet. So some of the most common causes for corneal edema like this are, progression of someone's condition, or especially with keratoconus, developing eye drops. Someone, with Fuchs or some other endothelial disease, or developing endothelial decompensation, where it just kind of goes kaput on us. We start running into that edema then. Corneal hypoxia can result and lead to edema like this as well as mechanical stress from the lens. If the lens is bearing down too tight on the eye, kind of suctioning on different things like that, all of that can contribute to edema. So some of the different things that we can do about that, some of our management strategies, if we want to look from just a lens standpoint, we can look at our different materials, going into a high or hyper decay material or a high hyper decay material, which Arlene is already in the highest decay material that's available or that we're able to get. So she is in the most breathable one. We can reduce our lens thickness. You can see in these like lens profile examples here, we can decrease the clearance, decrease the thickness of the lenses there, just kind of thinning things out. We could potentially add in things like fenestrations to the lens so that the lens doesn't suction on. You get a little bit more transmission of fluid, so potentially a little bit more oxygen. Do channels in the lenses. I will admit I have very little experience with fenestrations and no experience with channels, so I'm thankful there are some really good doctors out there who have a lot more experience with that than I do. And then we can also just loosen the lens overall. So, but if you take a look at the lens and overall everything there's looking fine, or in a case like Arlene's where it's like even down the road we're going to have to change the lens, we have to start off with a therapeutic change to begin with. We can add in something like a hypertonic solution, like a Miro. But typically adding on like a steroid, especially for patients who are having pain, an antibiotic when they have those bullae, because those can always rupture, and then you can have an open defect and you have to cover for that. I always like adding on a topical hypotensive, so something like brimonidine is usually what I use. So something that's an aqueous suppressant, so just decreases the outflow of fluid from into the anterior chamber. So you're just taking some of the stress off of those endothelial cells so that they can just work a little bit better. And then also Rho kinase inhibitors are kind of a newer thing within the last, maybe year or two here, where those have been shown to be very helpful. So Rho kinase inhibitors, most of us probably know that for glaucoma treatment. But there's actually been a lot of research and data showing how helpful it can be with managing endothelial disorders, like Fuchs, pseudophakic bullous keratopathy, different things like that. And this is just a summary of one that was a kind of a review article on the role of Rho kinase inhibitors in corneal endothelial disorders, published January last year. And again, I just highlighted kind of the main part here that published research shows the proven role of Rho kinase inhibitors in both promoting endothelial cell proliferation and suppressing apoptosis. And so, for me, I look at this and this is pretty incredible. We've always thought once endothelial cells are gone, they're just gone. You don't get any more of them. Well, now we've got a medication that's actually showing, hey, we can regenerate some of these, get more of them, so we don't necessarily need to, use them. And I'll tell you, I've had a number of patients that I've started prescribing this for. Right now, like I said, it is a glaucoma medication. So if you have a patient who has glaucoma, you can prescribe it under there, and that's helpful. But otherwise, for patients with Fuchs and other endothelial disorders, the insurance coverage is not great on it yet, but they are in the process of going through FDA approval for this medication strictly for the management of endothelial cell disorders. So potentially in the next year or a couple of years, we might be able to just prescribe this just for these patients. So for example, when we were looking at that corneal pachymetry map at the very beginning where we saw that progression, that gentleman, I put him on a Rho kinase inhibitor, and that's how his cornea changed. So we dropped down that edema significantly just by adding this onto him. And that was over about a year. And then the final thing that we can do, in some cases, unfortunately, some of these patients, they just do not recover when they have this decompensation, or if their Fuchs is bad. So we may have to look at doing like an endothelial keratoplasty, something like a DSEC or a DMEC, depending on the situation and the surgeon. So with Arlene, we got the edema to clear. In her case, we ended up having to debride that loose epithelium because she is very neurotrophic. We used an amniotic membrane to get everything to heal in. Everything looked nice and clear. We put her back in her scleral lens, and within about a day, her cornea was swollen again. She had that big blister again. So we started over, tried to put her just in a bandaged contact lens because otherwise her eye just got so beat up and started to break down without some type of coverage. But even a bandaged soft lens, her eye couldn't tolerate. So her cornea just decompensated too much, the endothelium had. So we ended up ultimately doing a DMEC in February of last year. And she still is, kind of recovering from that. It's a little bit different of a surgery for someone who has neurotrophic keratitis like her. So she's still recovering from that, hasn't been able to return to contact lens wear yet, but we're hoping potentially by the end of the year here. So, all right, so case number 2, we've got a 49-year-old female who we are fitting with scleral multifocals. She was a previous hybrid lens wearer, but was having some issues with corneal warpage, had some residual astigmatism, things like that. So we switched her over to Sclerals instead. Otherwise, she's got a little ABMD, but otherwise pretty unremarkable. She's coming in for a follow-up appointment, reports great comfort. Distance vision is really good. Left eye, she has a little bit of fogging that we're working on. Otherwise, we're just kind of fine-tuning the near vision. When we take a look at the lenses, she's got kind of low clearance superiorly over the limits. So the lenses are just sitting inferior a little bit. And I kind of see this, what I'm going to call our white striae. So I got some pictures of this, and we're going to, you might see this occasionally on patients where it's like, hey, we see these kind of like little lines coming through here. So I kind of got them from a few different angles. Hopefully you can kind of appreciate them little. But I'm seeing these like wrinkles here. So it's like, all right, got those. We take the lenses off and I put some fluorescein in, and this is what we see. So we've got all these different like elevated areas, these areas of negative staining, as well as kind of this dimpling or stippling along the outer edge here. And this is, those white striae is what we're seeing is this, these wrinkles here. So with Jen, what we have going on there is really some limbal touch or kind of bearing. So the lens is compressing down on the epithelium, or we'll call it some peripheral bearing, where the physical weight of the lens is just landing on that part of the cornea. And in that case, it's literally wrinkling the epithelium together. In that area, it looks like the epithelium, like when you just look at it behind the slit lamp, it looks really loose. But if you actually touch it, it's pretty solid. So the epithelium is just a little wrinkled there, but it's not loose or about to fall off or anything like that. In and of itself, by right away there, it's not much of an issue, but it can lead to some complications. It can lead to corneal edema because of that mechanical stress, can lead to neovascularization, keratitis. It's there long enough, can result in limbal stem cell deficiency. So we do want to get up and off that area. And really the biggest things that we can do are just adjusting the lenses. We can add some limbal clearance. So looking in that profile where we profile of the scleral lens, we can go where the red dots are on top of the black ones, to just getting up and off there, add a little bit more clearance. We can also improve lens centration. Like I said, in her case, her lenses were dropping a little bit inferiorly, so we can try to center those up a little bit, and that's what we ended up doing for her, and that improved things there. Jen also has, so she has two things going on. She's got that kind of wrinkled epithelium from that bearing, but she also has some epithelial bogging going on, where it's that stippling. The epithelium just has that waterlogged appearance after lens removal. Typically in these cases, our patients are going to be asymptomatic. It's going to look worse than it actually is. This is usually considered a pretty benign condition that resolves following continued wear. The epithelial cells just kind of have to adapt to the new environment that they're in. And once they've adapted, then they're fine. In some cases, it might, after a couple of months, if it's still not getting better, you might want to look at adjusting the filling solution, maybe going from a generic to one of the name brand ones, or going from a more neutral one to, just adjusting things that way. But I remember, the first time I saw this, I had a patient who, I think she was about 12 at the time that I fit in sclerals. She's like a -14, -5 in high school, volleyball player, and she'd been wearing corneal GPs, and she kept having issues where her lenses kept popping out while she was playing, which is obviously not great for her. So we switched her over to something like this. She was doing great, and I happened to see her at a follow-up, and took the lenses out and saw that, and I was like, well, this looks kind of funny. And I was like, she's not complaining. I don't see any like neo going on. And I was like, all right, let's just keep going. So I had her back a couple months later, and it was completely gone. And now I've been seeing her for the last, I don't know, probably 5 years. And every time I see her, her cornea looks great. So cleared up on its own pretty quick, and haven't had an issue with it yet, again. All right, case number 3. So we've got Karen. Karen is a 60-year-old female. She's a scleral lens wearer who has a history of advanced pellucid in both eyes. And Karen, I'm sure we all have those patients who they're kind of our, scleral lens patients where you recognize their name because you see them so many times. And Karen is one of those patients for me. She calls in today complaining of a painful red left eye. It started yesterday morning. Today is about moderate. It was pretty bad yesterday, but her eye's really irritated and she needs to come in. And here's the kicker. She filled her scleral lens with hydrogen peroxide. And I'm sure all of you are just kind of thinking, oof. The sad thing is this is not the first time she's done it. So hopefully, I think she learned her lesson this time. But entering acuity, right eye, she's about 20/30. Left eye, she's not wearing her lens because that eye is just so irritated. 2100. Right eye is unremarkable on slit lamp exam, other than the pellucid. Left eye, she's got lid edema. The conj is very chemotic. She has a big subconj heme just because of how hard it was to get her scleral lens out. She's got diffuse sodium fluorescein staining over the conjunctiva and diffuse 3+ PE over the cornea. So this is somewhat what our cornea looked like, but it was pretty much covering just everything. This is a picture of her eye from another time, because like I said, she's done this a few times. But this last time, it was just kind of everywhere. So she got all these SPK or PE across the entire cornea, very irritated, very photophobic, very uncomfortable. And so for Karen, we really have going on kind of a chemical exposure or a toxic epitheliopathy. These are kind of two ends of the spectrum for a similar condition is kind of what I think of them as. This really results typically from incorrect filling solution used in the lenses. So in Karen's case, she used hydrogen peroxide. Or it can also result from patients, especially if they're using a GP multi-purpose solution, so one of the thicker solutions, if they aren't fully rinsing their lenses and they just, take them out, fill them up and put them on, some of that solution is going to be coating the inside of the lens, can fill that post-lens tear layer, and then that can start to irritate the eye over the day. The picture here off to the side, you can see it's not quite as dense as hers, and it's a little bit more uniform across everything. This was another patient that I saw that, like I said, this is more of the toxic epitheliopathy end of the scale rather than the chemical exposure. But he was a patient, scleral lens patient, and he had just been filling his lenses with BioTrue. He didn't have any pain, any irritation, anything like that. But you could take a look, even looking through the scleral lens, you could see these gray little flecks everywhere across his cornea, whereas the SPK, take the lenses off, put the fluorescein in, and he just lights up like a Christmas tree. But again, he's asymptomatic. Patient symptoms, again, they can go anywhere from asymptomatic to very painful, very uncomfortable, photophobic, depending on what the agent was. So in determining how to manage these patients, I really look at what are the patient symptoms, as well as what is the offending agent, because that's going to make a big difference in terms of what we do with these patients. Thankfully, most of the time, if they're using like a contact lens solution or something like that, this is just going to be like a pH neutral. So, BioTrue is pretty pH neutral. ClearCare is pretty pH neutral. It's not acidic or alkali. But if we're dealing with potentially an acidic agent or an alkali agent, we have more of a problem there. For asymptomatic patients, just reviewing, hey, make sure you're using a preservative-free saline or tears. Maybe take a day or two off of wearing your lenses, and just kind of using as many tears as you can to just kind of rinse the front of the eye is all the more we need to do. For symptomatic patients, we really need to treat these like a chemical injury. We're going to stop our contact lens wear. We're going to start them on a topical steroid just to help with comfort. But again, also depending on what kind of agent this was, if it's an alkali agent or acidic agent, there's a lot of inflammation that comes along with that. So, sometimes we need to hit these patients, with like a Pred Forte or something like that every hour or two for 72 hours, and then we back them off again, depending on how bad that was. Again, hammering the preservative-free tears as well on these patients, things like that, just to get them back to a point where they're feeling more comfortable and they're able to do better. Case number 4. So we've got Jessica. Jessica is a 27-year-old female. She's a high myope with astigmatism. And she's coming in, she was a soft toric contact lens wearer who just wasn't getting the level of vision that she wanted. Vision kind of fluctuated around too much for her, so decided to try scleral lenses. She's coming in, says the vision is great, but she notes that her lenses her eyes feel sore and tired, usually around 6 to 8 hours of wear. But that goes away once she takes her lenses off. It goes away after a bit. And I asked her, and she's like, maybe 45 minutes, half hour, 45 minutes. Okay. Entering acuity is about 20/20 in the right eye, 20/20 in the left eye. Lens evaluation, the lens is centered. It's not moving. There's about 200 microns centrally, but it does look a little low over the limbus. Slit lamp exam, we take the lenses off. She does have a little bit of circumlimbal injection. There's a little bit of a compression ring too. She notes that, yep, sometimes I can see this little ring on my eye after I remove the lenses. Put some fluorescein in, epithelium appears, smooth. There's no staining. But as we look really close, we see this. And you might have a hard time seeing this. So I'm going to give it to you from a slightly different angle. And so right in the middle of that beam, if you're still having a hard time seeing it, we're going to point a nice little arrow at it. So we've got this little white fleck. So that little white spot right there is a subepithelial infiltrate. So she has a little epithelial infiltrate. So she has a mild keratitis as a result of essentially tight lens syndrome. Tight lens syndrome where the lens, might be fit too steep, and it's just, clamping onto the eye, especially if we're looking at that in the scleral landing zone. You're going to see blanching of the vessels, just pinching those off. But I honestly more often run into this where there's not enough clearance over the limbus and you're getting kind of some compression. And again, that lens is just gently hugging the eye. That, initially it's not too uncomfortable, but the more it's on there, the less comfortable the lens becomes. And then when they go to take it off, they kind of get this, my eye, can relax a little bit type feeling. Again, we can get that conjunctival compression ring. Patient symptoms are really going to vary, to just mild discomfort up to pain, depending on how bad this keratitis is. If you have patients who if someone has slept in a lens and the lens really starts to adhere down on their eye, the vessels can get really engorged and injected, and you can start to develop a keratitis that way. Again, that for me, usually what's kind of a big red flag for this going on with patients is they say, like, my eyes just feel like sore and achy, and then I take them off. And again, it's that kind of like relieving a pressure feeling. Usually tells me, all right, we're probably bearing a little bit too much. Some cases too, patients, you'll start to have more issues with difficulty removing the lenses. I had one patient who his lens was, really, really tight on his eye after he had fallen asleep in it. So he had been in it for he fell asleep watching TV in it, woke up the next morning, it was really tight on his eye. He took it out and he had these, kind of big engorged vessels, and he broke one. So he had a little, this is an intracorneal hemorrhage that he had there. From an adjustment strategy, lens adjustments, really what we need to do is get up and off the limbus. Whether it be adjusting the limbal zone, so just clearing things out that way, so lifting things up, or even widening the inner chamber, going to a larger diameter lens, just so you're getting further out away from the limbus can be helpful there. If it's the landing zone, obviously you can loosen the landing zone, widen it, so we're just extending out that pressure a little bit, widening out the range that it's landing on, or potentially changing design, going from a spherical to a toric to a quadrant specific to potentially even a freeform lens design, so that you're just getting optimal kind of landing on those lenses and there's not too much pressure in one area or another. Therapeutically, if someone's got these little subepithelial infiltrates, we're going to discontinue lens wear for a short period of time. I usually will start them on either a steroid or a combination drop. I usually like to use a combination drop, antibiotic and steroid, just for some coverage there. But this is mostly a inflammatory reaction. So we need that steroid to calm down that little infiltrate. It's going to make their eye more comfortable and help calm down some of that swelling in the area as well. Sometimes I feel like the most common patients I tend to see this on are actually post-LASIK patients. I think they have where the edge of the LASIK flap is, they've got that like little ridge right there, and so the lenses they can settle a little bit more, run in there, and they can almost start to develop somewhat of like a DLK type reaction, where they get a strong inflammatory reaction at that interface. So you've got to really watch those patients and make sure you hit them pretty hard with steroids to start off with. Every 1 to 2 hours for the first day or two until that starts to clear up. Case 5, we have Alice. Alice is a 62-year-old female. She's a new patient to me. She has a history of keratoconus, pretty mild form frost in the right eye, and kind of a moderate in the left eye. We've got her topographies off to the side here. She wears a daily Ocular Comfort Plus in the right eye and a scleral lens in her left eye. She was fit by another provider in our area who retired a few years ago, and so Alice's last exam was about 3 years ago. She hasn't seen anyone since. She reports great comfort, and all she wants is she just wants a new scleral lens for her left eye. Entering acuities, 20/20 in the right eye, 20/25 in the left eye. When we take a look at her eye, the right eye, overall everything looks great, but you can see in the left eye, she's got, this neovascularization. She's got these vessels growing in, and then these white patches. She's got one in her left eye that's kind of superior nasal, and then she's got a really faint one that's almost more like a halo with a big vessel coming into the middle inferior nasal. The other one is superior temporal, this bigger one. When I take a look at the lens on her eye, she has about an area that's about 4 millimeters centrally that's clearance, and everywhere all that lens is just touching and smashing everywhere else on her cornea. So she got quite a bit of bearing. So for her, Alice, she's got corneal neovascularization, and then this has also led to lipid keratopathy with her. So as those vessels come out, they're now leaking lipids into her cornea as well, and that's what those white patches are and that halo. And this is really just an ingrowth of blood vessels, can result from hypoxia, poor lens compliance, so patients not following up like they're supposed to, and lens bearing. So again, her lens, pretty much everywhere where I was touching, there was at least some haze, if not neovascularization, and that lipid keratopathy developing. Really, our management strategies with these patients, if it's a hypoxia issue, going with that high hyper or the highest DK material that you can, minimizing thickness and lens clearance as much as possible. There's some type of mechanical stress, so the lens is bearing, just making sure that we have proper clearance, make sure that the lens doesn't fit too tight. And if patients are over wearing or extended wearing their lenses, just tell them to stop it. This is a picture of a patient who had been sleeping in his scleral lenses, and he developed some neovascularization and some scarring there because of that. And so really to halt that progression, it's not going to go away, that scarring won't go away, but to halt its progression, we need to stop that extended wear. So reiterating that to our patients. Some patients, if therapeutically, if it's really engorged vessels, we can put them on a topical steroid. Topical cyclosporin can be helpful for long-term management. Increasing ocular surface lubrication can be helpful as well. In terms of using artificial tears, punctal plugs, tear via. Sometimes, some patients will put autologous serum tears in their lens. That can be helpful depending on the condition, especially some of those graft versus host patients, severe ocular surface disease, different things like that. They may develop neovascularization for a different reason. Otherwise, in some of these patients, they might receive Avastin injections, stromal Avastin injections. That's what this is a photo of here with those large vessels. I have one other patient who has lipid keratopathy like Alice does, but his lipid keratopathy is pretty central. It's right next to the edge of his pupil. And he used to have this really big vessel leading to it. But the cornea specialist who referred him to me has been doing Avastin injections in the stroma about every 3 months for about the last 4 years. He still gets them, but the vessel is gone. The lipid keratopathy hasn't progressed. They can also do vessel cautery as well to cut off some of those to just try and kill them as well. So yeah. And let's see. So case 6, we have Colton. He's a 22-year-old male. He has a history of keratoconus, left eye worse than the right eye. He had cross-linking in 2014, and he wears scleral lenses. And Colton, again, he's a young guy, and he is one of those patients of mine who is terrible at following up whenever you tell him to. So his last appointment was about 18 months prior. He's coming in complaining of painful eyes, left eye more than the right eye. And it's been noticeable for a few months. And he says about 4 or 5 months, he's been noticing, my eyes kind of hurt a little bit. But it's gotten really bad and intolerable here in the last week. So he decided to finally come in. Entering acuity, so he's wearing his lenses. Entering acuity, right eye is 20/30, left eye is 20/50. Slit lamp, right eye, lens looks good. We've got clearance centrally. There's a little bit of injection, a little bit of superior corneal neo. But once we remove the lens, everything looks pretty smooth and intact. So overall, that eye is looking good. But for the left eye, let's take a look at some photos here. So this is what his left eye looks like. So you can see on the left-hand side of your screen, just a front photo there, and you see that nice big white ring. And that ring basically denotes everywhere where that lens is bearing on his cornea. And you can see that nice little slice here off to the side where the lens, the back of the lens and the front of the cornea meet. And now we've got this large area of bearing right through the middle there going on for Colton. So again, Colton's having some issues with corneal bearing, where the lens is just landing on the center. It's causing an epithelial erosion. It's essentially like an abrasion. And this usually results when patients haven't come in for a while and their condition has progressed. So even though Colton has had cross-linking in the past, his keratoconus still progressed, and he just hasn't come in for some of the follow-ups. So we haven't been able to monitor that quite as closely. Management, really, to start off with, we're going to treat this like an abrasion, use a topical antibiotic, potentially a topical steroid, depending on how uncomfortable he is. We might even use a bandage contact lens. If you can get one to stay on their eye, that can be helpful. In some of these cases where their eyes are beaten up enough centrally, I've used amniotic membranes on them, and that has been really helpful to heal that in a lot faster and help cut down on some of the scarring, because that's the big issue we can run into with that bearing is we can get that central scarring, and then that can limit our vision, and we might need to look at doing a transplant for these patients. Typically when I do an amniotic membrane on these patients, I'm usually using cryopreserve just because it's hard to, especially someone like Colton, it's hard to get a soft contact lens to stay on his eye. So the ring from the cryopreserve membrane holds on a little bit better. But really, the main goal once we get everything healed in is we just have to increase our lens vault. We got to get the lens taller. Ideally, we'll also refer patients out for cross-linking again, just to like lock them in place so that we don't run into this progression. I have another gentleman here recently that he was another one. I haven't seen him in a year and a half, and he comes in, in an emergency one day because his eye is hurting, and sure enough, his keratoconus has progressed to both eyes, and that cornea is just smacked right into the back of the lens. So we got him calmed down, and now I'm sending him to a surgeon for cross-linking. Colton, unfortunately, he's a little too advanced. His corneas are only about 250 microns thick, that he doesn't qualify for cross-linking anymore, and he's not at a point in his life where he wants to have a corneal transplant. So he just wants to let it ride for right now. But we'll see what happens with him. And then finally, so the last thing the last case I wanted to go over was microbial keratitis. And I don't have any examples of microbial keratitis related to scleral lens wear. I reached out to a number of my colleagues as well, and none of them had any direct scleral lens related microbial keratitis cases. So instead, I just went and found some research on them and a couple of cases and things like that. So I kind of wanted to go over that a little bit. And so with microbial keratitis, there's not as much data. We don't have as much information on it related to scleral lens wear as we do with like soft contact lens wear. But this was a study that was published in March, just earlier this year, again, by some of our excellent colleagues. And really, this was a survey-based estimation of corneal complications where they sent out a survey. Many of you may have participated in it. I remember participating in it and filling out this survey. And they kind of went through and then made an estimation on how often do we run into this. And in this, they were basically, through this survey estimation, they looked at about 72,000 scleral lens wearers and found that the incidence of microbial keratitis among scleral lens wearers, for patients who had to discontinue scleral lens wear because of microbial keratitis, that incidence was about 0.45%. Now, that seems pretty low, but to give you an idea in terms of the incidence of microbial keratitis among daily soft contact lens wear is only about 0.019%. For the incidence of microbial keratitis among extended wear soft contact lenses, about 0.19%. So rather than daily wear is 0.019, extended wear is 0.19, and then among corneal GP wearers, it's about 0.012%. So significantly higher among scleral lens wearers, potentially, at least from what we've seen here, compared to other contact lens modalities. In some of the various case reports that I could find related to microbial keratitis, here are just a couple of them. The main kind of overlying theme of all, most of them, is it was often associated with poor compliance. Patients either using the wrong filling solution, using tap water on their lenses, using the wrong cleaning solution, storing their lenses in preservative-free saline, or patients overwearing and sleeping in their lenses. So oftentimes, with patients who do a good job of following the rules and doing what they're supposed to, there was a really low incidence of I didn't find any case reports of a patient that just spontaneously developed one. Most often, it was associated with someone not doing something correctly. But among microbial keratitis, for soft contact lens wearers, we know the most common culprits are Pseudomonas, Staph aureus, and Serratia marcescens. But we don't know what the most common culprits are among scleral lens wearers. Many scleral lens wearers, at least currently, have other ocular pathologies going on. They have severe dry eye, they have corneal transplants, they've got just weird things going on. So they might have more atypical ulcers. I'm sure many of you have received, or if you didn't receive, there's a study that was recruiting for the multi-center scleral lens study sent out by the Scleral Lens Society. I got this email a few months ago where we're trying to figure this out. We're submitting cases to figure out what is the incidence of microbial keratitis. What are the culprits most often associated with it? And I think, like we saw earlier, the use of scleral lenses is rising significantly, and it's predicted to rise significantly. And there's also been a big change in terms of more normal eye patients starting to wear scleral lenses as well. Not always sick eyes, a lot of patients with high astigmatism or multifocals, things like that. And so I'm curious, I'll be interested to see how this changes as we have more of those normal eye patients who might be less susceptible to some of these more atypical ulcers and what happens there over time. But with microbial keratitis, really kind of the big thing is culturing. There's typically a rule of the 1, 2, 3 rule for culturing that, if you see an ulcer, if there's a 1+ anterior chamber reaction with that ulcer, you want to culture it. If the infiltrate's greater than 2 millimeters, we want to culture it. If it's within 3 millimeters of the center of the cornea, we want to culture it. But again, especially in some of these patients, many of them, especially more sick eyes, they could have very atypical ulcers. So I don't think it's ever a bad idea to culture any of these patients, especially some with the transplant, something like that. And being in a private practice where I'm at, I don't have auger or things like that right on hand, but we have it's called Quest Diagnostics. I know there's some other companies out there, but that are nationwide, where they can get you set up with the little swabs. You can put them in the little culture tubes, and then they pick them up, take them off, run the test that you need, and just email you the test results back. And so that's really helpful and handy and pretty easy to get set up with. Typically when treating an ulcer, it's, even before you know what it is, you want to start treating empirically. Typically starting with a fluoroquinolone is usually the best bet. Among soft contact lens wearers, we know that Pseudomonas is usually our most common culprit. So treating with chlorofluoroquinolone, so Besavance, is really the best option. It's the FDA, it's the only medication that's truly indicated for Pseudomonas ulcers. Other ones might have coverage for it, but it's specifically indicated for Pseudomonas. So that is usually my starting point, is either a 4th generation, so Moxie or Gaddy, and then Besavance if my pharmacist has it on hand. And then if, as long as the ulcer is responding, the cornea is getting better, just continue the course. If not, then we can always add on something like fortified Vanco or fortified tobramycin as we need to as well. So just kind of in summary, in choosing a management strategy, and depending on what's going on with your eye, there's kind of like 4 main questions, and this kind of goes along with just about anything. But there's 4 things that I kind of always ask. What are the patient symptoms? What are the clinical findings? What does the lens look like? And then what else is going on in the eye? And kind of answering these questions, that really helps me figure out what we're going to do for this patient and how we're going to manage that. And with that, I'll say thank you, and I'll switch things over. This is just a picture of my son, Emmett, as he is enjoying a donut that we had a couple of weekends ago.